It's Professor George Dagher from France. I know George for many years. We're working together in a variety of European research programs. George Dagher had many research fields in metabolic diseases, neurology, was head or director of the clinical research infrastructure at INSERM, and also leading the French biobanking infrastructure program. And in this context, he became more and more involved also in the environment in which we do research. On the one hand, in standardization, quality control, how we can make research data reproducible, but also other issues like general ethical issues that impact on our field. And George Dagher is visiting professor at our university, but he's also visiting professor at the University Milano Bicocca, and also what I have learned at the Chinese Academy of Sciences. And maybe there are many more things. Please, George, add elements that I have missed. We are looking very forward to your talk, and hopefully you will be also able for questions and discussions after your presentation. So, George, the screen is yours, not the floor, unfortunately, but the screen, and we look very forward to your contribution. Thank you.
Thank you, Kurt, for this invitation to give a talk. It's a real pleasure to do that at the Medical University of Graz. I wish to discuss this topic, supplying evidence in health emergencies, and it's of course related to the current pandemic we know. It's not a political criticism or evaluation of public health policies in France or elsewhere. It's just food for thought, and I did not reach any conclusion. It's just work in progress. And hopefully the discussion or further discussions in the next few months will help bringing much more clarity in what should be done in health emergencies. So the take-home message of this presentation could be: we need large-scale trials, both on the national and international levels. We need protocols, not only clinical protocols or therapeutic protocols, but also public health protocols, sitting on the shelf and ready to start when a pandemic or emergency strikes. I started thinking about this when we in France starting having a debate, of course, among politicians, and this is normal, but also in the scientific community, what should be done in a pandemic. And I thought, okay, we had a previous epidemic, a very serious one, more deadly than the current one, the Ebola epidemic. And what did we learn from Ebola epidemic that we could have implemented in dealing with the COVID-19 pandemic? And I will start by some ethical questions in the time of pandemic that were raised during the Ebola epidemic. And there is a large number of publications on this specific topic, which I have reviewed many of them, and this is just a synthesis of these publications on ethical questions and also on methodology in clinical trials, or more exactly in therapeutical trials. So there are three major ethical questions that raised during the Ebola epidemic. The first one is questions of individual medical ethics, in particular surrounding the compassionate use of experimental drugs and vaccines. The second question is whether we should allocate resources to these experimental treatments or to infection control. And the third ethical question, how resources should be spent in the long term. For example, building a public health and clinical infrastructure that can cope in an epidemic instead of propping up a weak infrastructure during a humanitarian crisis. These are the three main questions that the Ebola epidemic raised a few years ago. And it could be summarized by this figure as done by Garrick in the British Medical Journal. You have short-term and long-term decisions that could be taken, either on an individual basis, like compassionate use of experimental drugs, or public health level, like isolation and infection control, and on the long term, health system preparedness and research and development into neglected disease. During the Ebola epidemic, short-term use of experimental drugs attracted far more attention than it deserves. And this distracted from the practical and urgent business of controlling the epidemic. And at least in France, this is what happened during the Ebola pandemic, during the COVID pandemic, sorry. So during the Ebola, commentators argued about whether randomized trials were required in the heat of the epidemic, whether the level of personal risk, what is the level of personal risk that might be acceptable for recipient, who should receive the drugs, the therapeutic, and how to ensure informed consent, and whether health professionals should get preferential treatment, among other things. Similar questions were raised during the COVID-19 pandemic. I will concentrate on the moral or ethical challenges surrounding the compassionate use of experimental drugs and vaccines, which are very complex, and there is a heated debate which arose during the Ebola epidemic, but also during the COVID-19 pandemic. And we lost the public health perspective in the noise of this heated debate among politicians, but also among scientists. One conclusion from the Ebola pandemic could be that governments, international organizations, and funding agencies need to take a wider perspective and a longer-term view on health system preparedness when it comes to effective prevention of epidemics. Once an epidemic occurs or a pandemic occurs, rapid deployment of proved methods of infection control should take precedence over experimental treatments. So as I said, I will focus on the first of the three ethical questions, the one surrounding the compassionate use of experimental drugs and vaccine. The idea that medicine should be based on research and evidence is surprisingly a recent development. It came from an observation made by Chalmers, working in a Palestinian camp in the 70s. He has been told that young people with measles should not be treated with antibiotics unless they have a secondary infection. Later on, he found that what he has been told was wrong. And 6 controlled clinical trials had shown that antibiotics given early to children with measles were effective at preventing serious bacterial infections. So Chalmers and his team in the 70s set about systematically scoring the medical literature for controlled clinical trials relating to care in pregnancy and childbirth, a field in which evidence was shockingly poor. And in the 1990s, Chalmers was central in founding the Cochrane collaboration, which aim to follow this model and synthesize evidence across other medical specialties. Today, it's common for doctors to use evidence alongside their clinical expertise and the patient preferences to work out what to do. And the bedrock of evidence is built from systematic reviews in which researchers follow standard methods to analyze all relevant, rigorous evidence to answer a question. These reviews often include meta-analysis, that is the statistical combining of data from multiple studies, such as clinical trials. Koshan and other groups published more than 24,000 systematic reviews in 2019 alone. We should know that systematic reviews are very slow to produce because for two main reasons. Because academics have to work hard even to identify relevant clinical trials in publication database. The studies are not clearly tagged, and researchers who do trials rarely talk to those collecting them to reviews. The Koshan median time to produce a review is more than 2 years. Updating them is not that rapid when new research is flooding out, for instance, in the case of COVID-19. So during the pandemic, Koshan cut the time of some reviews to 3 to 6 months. During the present pandemic, many doctors and researchers did race to launch clinical trials, but most of them were too small to produce statistically meaningful results. This is a figure from a paper published in Nature in May 21, and where you can see that 40% of the clinical trials had less than 100 patients, a size sample that is generally too small, and many of them were less than 1,000 patients. And this is an example of one of these clinical trials where they wanted to include about 7,000 patients and subjects, some of them asymptomatic, others symptomatic. You have inclusion and exclusion criteria, etc. I will not go into the whole detail, but it ended up from 4,000 asymptomatic to about 200 that contributed to the primary endpoint, and from 2,200 to 211 and the other arm that contributed to primary endpoint. So from about 7,000, we ended up with about 400 that contributed to the statistical analysis. There is a great loss of patients during the whole process. And this is the well-known recovery study. They were supposed to recruit 40,000 subjects, and it ended up in 6,000 subjects, controlled and treated, that were included in the study, with a simple outcome, death at 28 days, a simple consent form to go quickly. 176 centers from UK contributed to this study. One major result, steroid dexamethasone reduces death rate, and this is a summary of part of the results. 482 out of 2,000 patients in the dexamethasone group, and 1,100 out of 4,000 patients in the usual care group. So you can see that they started with 6,000 and ended up with about less than, well, with 1,500 patients at the end. So what is evidence-based medicine? The definition, I think many of us or many clinical researchers don't go to the original definition of evidence-based medicine, which is the following: conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patient. So it is conscientious, explicit, and judicious use of current best evidence. And while reviewing the literature for this presentation, I found a large number of publications dealing with evidence-based medicine. And the question I asked myself is how evidence is translated in other languages. So in English, evidence is broadly construed in anything presented in support of an assertion. So how would a Frenchman understand evidence-based medicine if he doesn't go back to the original definition, which I showed in the previous slide? That is the conscientious, explicit, and judicious use. The French guy would understand evidence as a proof, as a solid rock proof. And how would a German-speaking clinician understand evidence? And I found, just translating by Google Translate evidence, that you have in the German language more than 5 or 6 possibilities to translate evidence. I don't speak German, and I don't know how you would translate evidence and how you use currently evidence-based medicine. How is your current understanding of evidence-based medicine? But this is a question which we would approach and discuss probably. So there are 3 pillars for evidence-based medicines. There is published evidence in the English understanding of the word evidence. There is the clinical judgment of the clinician and the patient's values and preferences, which we should not forget. It is not evidence that determines decisions. Rather, it should be the people who apply the evidence and to whom the evidence applies. So we all know this process, the idealistic knowledge of producing evidence-based results. It relies on a progression of investigation from pathophysiological theory, animal models, small human trials, phase 1, phase 2, phase 3, meta-analysis of all available data. And this is very good to provide a robust answer as to whether an intervention works, does not work, or may cause harm. And this has very strong evidence in the last decades of its solid. It relies on solid grounds to provide answers to many of the therapies that are put in place to prevent or to cure diseases. But this obviously idealistic knowledge development is not realistic in time of emergency. And I have looked at how people would translate evidence-based medicine in time of emergency. And I found very few publications dealing with this. This is one of them, published in 2021, a few months ago. And it deals with evidence-based management. And this is the statement: in times of crisis, clinicians may feel that their strong inclination to prescribe potential harmful unproven therapies for their patient is supported by beneficence, a tendency that has been described as commission bias. We suggest that initial evidence-based management, we is pain, that initial evidence-based management start with education of the patient and his or her close contacts about disease progression, isolation and the definition of quarantine. The approach should then focus on four main categories: contagion control, evidence-based outpatient therapeutic that can prevent progression, mitigation of secondary infections, complications, and supportive measures. This pandemic highlighted that policymakers could recommend what to do without waiting for rigorous clinical trials, as these can take many, many months before providing a solid proof. For example, wearing of surgical mask could be just common sense versus bulletproof evidence of randomized trials. Unfortunately, people have focused too much on randomized trials as the only source of truth, while common sense could be also very useful in such situations like a pandemic. And often a pragmatic assessment based on a range of different evidence like surveys, natural experiments, observational studies, and trials, and they mix them together to give a picture of whether something is worthwhile. Probably this is the best approach in times of pandemic. And again, the take-home message to face the future pandemic would be to have protocols sitting on the shelf, which include public health protocols, clinical protocols, or therapeutic protocols, which include large-scale trials on national and international basis to meet a number of patients which is sufficient to draw statistically significant results, to have such protocols ready to start when a pandemic or emergency strikes. And that might be very helpful to face the next pandemic. Unfortunately, in France, we did not learn much from the Ebola epidemic, and hopefully we can put up some solid based approaches to face the next epidemic. If you want to know more about this topic, you can consult the FDA COVID-19 Pandemic Recovery and Preparedness Plan, which is a summary report. There is not much in this report to face the pandemic, but it's a very good review of what should be done. You have a very interesting paper published in New England Journal of Medicine by Rory Collins and colleagues, including Martin Landry, who is one of the leaders of the recovery clinical trial. And the paper is interesting. It's called The Magic of Randomization versus the Myth of Real-World Evidence. And the comments are even more interesting than the paper. And the whole mix of the paper and the comments is of great value and give food for thought what should be done in case of health emergencies such as pandemic. And here we have systematic reviews of a number of initiatives that were taken during the COVID-19, if you wish to have more information on such initiatives. Thank you very much.
Yes, thank you so much, George.